This is Heal Your Mind, Heal Your Body with Dr. Schuyler. Discover how your thoughts manifest disease and what you can do about it. Here's your host, Dr. Schuyler.
Welcome back, beautiful souls. Today we are continuing the discussion with Dr. Safder, the director of the Neurogastrointestinal Motility Disorder Clinic at Arnold Palmer Hospital in Orlando, Florida. We're discussing the brain-gut interaction disorders such as IBS, abdominal pain, gas, bloating, and how the mind-body connections, your emotions, your vagus nerve, your autonomic nervous system, the limbic system, the neurological control of the GI motility function, and the brain of the gut called the enteric nervous system. And the number one question I get from GI patients after medications and medical clearance and all these testings, all to no avail. The number one question is, and outside of the post-secondary infections, people always ask me, why do I have IBS? Why do I have IBS? And that's kind of where I take over after you guys, I call the physicians have medically cleared it, is when I want to dive into what exactly is the neurobiology behind this. And what I have found is you were using the word insult. When there's an insult, there's an insult. And this is where it crosses over. Okay, well, where is the initial insult? It's not a post-secondary infection. And this is where I break it down into the glue that binds the mind and the body together, emotions. Different attachment styles, chronic invalidation through people that we love or through social media. And attachment style is a really big part in autoimmune and GI disorders. Attachment style is a really big part in trauma. So the insult is where it kind of goes over into my field. What caused the insult that led to the disruption of the microbiome? And we do know anxiety and depression disrupts microbiome. It's a bidirectional communication. So some with prolonged high anxiety starts to impact the limbic system. It either goes in fight, flight, or frozen. And one thing I do know is I follow the polyvagal theory, and it's part of what connects the mind and the body together, safety-based. So if you think of it this way, if you have prolonged anxiety, it's going to disrupt your gut microbiome. You're either going to be in fight or flight. Chronic anxiety, chronic depression, your body slips into a frozen response, something called dorsal vagal complex. So when I treat someone, I can see based on where their symptoms are. Below the diaphragm is typically a frozen or flight response. Above the diaphragm is a fight response. So when you refer patients to me and they are coming in with constipation, I'm like, oh, we have a chronic frozen response. They've been, dorsal vagal complex been activated for too long. If they have IBS, they're usually fluctuating between flight and frozen. So when you mention the insult, I want to back it all the way up into psychoneuroimmunology. Psychoneuroimmunology, how the thoughts, the emotions infiltrate the roughly 30 trillion cells, which can be an insult into the gut microbiome.
Absolutely.
Right? Makes sense?
100%. And so polyvagal theory, and to just kind of go back to the innervation, how we're wired, our central nervous system, our brain, right? And part of our CNS is also our ANS, or autonomic nervous system. And there's two arms to that: the sympathetic, which is your fight and flight, and your parasympathetic, which is your rest and digest. And this vagal nerve that courses from our brain down through our diaphragm and into, our gut, and is such an important nerve, it controls our rest and digest function. So when I refer to the brain of the gut, the enteric nervous system, this enteric nervous system, which actually innervates the myenteric plexus and the Meissner's plexus and all of these complex, nerve pathways at the mucosal level and in the muscle layers, is under the control of this autonomic nervous system, which is ultimately part of your central nervous system. So there is truly a brain that controls the gut, the enteric nervous system. And that's what motility disorders are. And that's my introduction that you so kindly said. You said, I'm a neurogastrointestinal motility disorder specialist. And that's exactly what motility is. It's neurological control of GI motility and function.
And I want to piggyback off something you said too. It is, and this is why I love working with APH, it's not in the patient's head. It is not in the patient's head in any capacity. And we have another mutual patient, and she actually had this brilliant question that I wanted to ask on her behalf. She's just a backstory. She's a 20-year-old female. She's doing fantastic now. But I said to her yesterday, what would you want to ask Dr. Safder if you ever could? And she's like, I was almost admitted into a psych unit. I was told by 3 different GIs that I'm crazy and they want to admit me because I'm going psycho, I'm going psychotic. So she says that you changed her life. You saved her life because everyone else wanted to admit her that she was a psych case. And just for the record, she's doing fantastic. She's in college. She's thriving. I started seeing when she was 15. So she wanted me to ask you what was the turning moment when you realized that sometimes traditional protocols, gold standards, don't work, and that using medication doesn't work? Her question was, this wasn't working. What made you think outside of the box to help your patients? Because your approach changed my life.
You're so right. So for this particular patient that you're talking about, it was an exam that I was doing on her, and I was examining her, and I was testing. I used a little pinprick to kind of test just her sensitivity in her arms and legs, and then I also had performed on her rectal manometry and a rectal exam to again gauge her rectal sensory threshold because she was having a lot of constipation problems. So we routinely look, we look for areas of pain. Is there hemorrhoid? Is there a tear? Why all this discomfort with the stooling? And we have norms. And when you do this a lot, you kind of know, okay, this is a normal threshold, for a person of a certain age and gender and so on and so forth. And her exam findings didn't match up. I was like, the test I'm doing, what I'm checking for, her response, especially her pain response, was so exaggerated. And it wasn't, again, it's not in their head. I mean, she had real tears. Her heart rate was elevated. There was very tangible evidence that this was causing her more pain, even though what I knew was otherwise not necessarily a stimuli that would have provoked or caused that much pain or discomfort in somebody who didn't have a DGBI. And so to your point, we do a great disservice when we, basically say something like it's in your head, or this must just be, how you cope, or you cannot. It's such a disservice to our to patients who are struggling with this, because, and this is the reason why there was actually a shift in terminology, because a few years ago, disorders of brain-gut interaction were actually called functional disorders, and that was it wasn't the best way to describe it, because in medicine you describe organic illness, which is something tangible. You can measure it, you can see it, you can test for it, and it kind of will give you an answer. And if you can't see it and you can't test for it and you can't find it, well, it must be functional. And so it kind of lumped anything that wasn't tangible or wasn't measurable into functional, which i.e. was in your head, or you just didn't know how to cope with it, or what have you. And disorders of brain and interaction explains the biology of what's happening, right? It is a true there is a basis for it. There is hyperalgesia, there is mucosal inflammation, there's upregulation, downregulation, and it's bidirectional, abnormal pathway signaling between your brain and your gut, with probably a background of why it started. And one thing I didn't talk about is genetics, because some people are genetically predisposed to respond to certain ways because that's what their genetics dictate, right? So again, it's not like one approach or one treatment is going to give you the same results in all of your patients, because we all have different DNA and our fingerprints look different and how we respond is different and we are wired differently. And so the GI community and neurogastrointestinal communities, I think, have really championed the cause, and disorders of brain-gut interaction are now more frequently recognized and better understood. And our job is to really decrease stigma, because that is just going to be a disservice to our patients, and our patients aren't going to seek the appropriate treatments because they're made to feel like they're really made to feel that their symptoms aren't, real. And that's the first thing I say. We have to acknowledge that this has affected their life in a big way, and they're reaching out for help. So I think, like you said, our words matter.
Yeah. I did this last podcast on chronic invalidation, and I talked about medical invalidation, how it exacerbates the disease process. Either someone becomes hyper independent or their symptoms get worse and they stop communicating. And I'm at this point now, I'm very blessed where I'm getting people from all around the country. So I'm hearing all those reports of physicians inadvertently are doing invalidation. What I have noticed consistently of APH is your group, I want to use the word never, invalidates this experience. And I'm using that word, intentionally. You guys make a point to validate, hear, and empathize. What that does to someone's healing response, that the bond that forms is almost indicative of how well they'll heal. And I wish so many people understood that when physicians offer that empathetic understanding, it's not in your mind. It promotes wellness in the patient. And you guys do a remarkable job of that. Patient after patient that I get, every single time it's like, yeah, APH validated me and this is why I'm here. Now, what can I do about it? So I want to tip my hat to you all because I don't see that all the time. It's very unique, I would say, to your practice and my experience and my referrals.
Well, thank you for that. But there's just one simple reason. We treat everybody the way you would want yourself to be treated, right? If you were in those shoes and you were desperate and you were seeking and nobody's there to even validate what you're going through, how's that going to help healing and getting better? And so I think that comes from just us knowing and seeing, and it's a very patient first approach. And I don't want to pretend that we always have the answers and we always have the solutions and we're able to fix and help everybody. But even if we can, we're honest and we will at least, we know that the symptoms are real and we may not have the answers and we may not always have the fixes and the cures, but that's important. And there is no, there is no shame in saying that.
Yeah, well done. Okay, another question. Have you noticed any pattern working with pediatrics with brain gut disorders, certain characteristics or personality traits? I have it on my end, but I've been so curious all this time, like what you see clinically in your office.
Yep. I think there's definitely some things that you start to pick up. And it could be in the simple mannerisms, right? When a patient walks in and you can tell, I just look at their hands and I can see their nails are chewed down to like nothing, right? And I'll just, I'll be like, so, do you sometimes nail bite? Is that like a nervous habit for you? Unfortunately, in this day and age, especially because I deal with kids, I deal with, a lot of teenagers, their coping strategies, right? Like they're struggling. They're struggling with a lot of things. And sometimes they're coping in not very healthy ways. Sometimes I'll seek, evidence of cutting or something else, that's a physical reminder that they are, struggling with something. Sometimes I can just tell based on the personality, how they talk, they're type A overachievers, they're go-getters. Sometimes I can tell the family dynamics. I walk in and I'm like, holy moly, like you can cut the tension in the room, right? Mom's there, dad's there, or whoever, XYZ, whatever relationship, and you can tell. And I always talk first to my patient. I don't care if they're verbal, and if it's a baby, I'll still like coo and, play with the baby first before I turn to the mom and dad. Be like, so what brings you guys in today? And of course, if my patient can talk, whether, they're 3 or 23, I always ask them first. And when I'm trying to ask the patient, I'm like, hey, tell me in your own words what you're feeling. And I'm like getting interjections from everybody else in the room. I'm like, I promise I will listen to all of you guys, but let him or her speak first, right? So it's just listening and sometimes the interactions in the room. I think the social dynamics, the family dynamics, the teenager who's like nonverbal, who will just like, I don't know, like grunt at you if you ask a question. not really give you a full sentence answer. So, you see it all, and you kind of, you need to have a high degree of, I guess, emotional intelligence to kind of read the room and just sort of go with the flow, and just sort of pivot with your patient. And then sometimes I'm like acting really cool with them. I was like, yeah, like me too. Yeah, I'm a Swiftie. Just try to like connect, because I think that's the first thing is you just have to find that bond, and have a
Yeah.
therapeutic alliance. Like they need to trust you. They don't want to be there. Maybe they were dragged there. Who knows, right? So it's always you have to build that trust.
Yeah. So you were saying things that I experience. I could almost take a patient and put him in. I can take a patient, put him in a mold. It's when I see, especially constipation or IBS, it's perfectionism, overachievers, great grades, typically good kids, almost all good kids, some sort of dance or performance or sports.
Driven,
And
very.
yeah. And then I get into attachment styles, and I see the same thing when I go to do an intake session, and the kid's not talking. And I'm in a place where I need to understand the child. But right there in that first 3 minutes, now I know what the problem is. And the kid hasn't said a word. And it's just these loving, loving parents that we just want our child fixed. We just want our child healed. So let me give you all the information I can. But that's a very contagious, stressful vibe that the child's getting, which internalizes. And then that puts them in a frozen response, dorsal vagal, or puts them in a fight or flight response. So I'm glad that you see it clinically, because that's the first thing I noticed in the first 3 minutes. What's the familiar dynamics? What's happening? Because what's that stress putting on there? And I have a child with autoimmune disease. So after COVID vaccines, I had to check my vibe in the doctor's office. So I'm like, zip, zip, lock a pocket, no talking, let her talk. Because I know exactly what y'all are experiencing. So I dive more into this, but thank you for validating kind of for me, like, yeah, I legit see that on my end. Attachment style, chronic invalidation, emotions, limbic, all of that plays such a huge role. And what I'm trying to convey to parents is we want to fix our kid. We want to speak for them, but that robs them of their autonomy to become empowered over their own health. And when the child can have autonomy to learn to speak to physician, to learn to speak what their problems are, and then to learn to get that feedback back, it's exactly what you just said. You're building a therapeutic bond and alliance with that patient, which in my world is a number one indicator for patient success, is the bond between myself and the patient. So I want to advise parents, as one right now, if I'm pointing a finger at y'all, I got 4 pointing back at me. We want to advocate for our children, but I typically like to say over the age of 10, please let your child speak. Please let your child learn to advocate. Please let your child learn to feel empowered, and then let them learn from the physician. And as much as we want to solve it, let us come second after the child communicated to the physician. Does that sound reasonable for you on your end, what you experience?
Absolutely, absolutely. And especially because we were talking so much about DGBIs and how you feel things, visceral hyperalgesia, how you feel things. Nobody can speak for you. Nobody can say how you feel it, because you're the one who's feeling it. So it is important, in whatever words you can string together. It doesn't have to be perfectly articulate. Just be able to say what it is that you're feeling and get more comfortable saying it, because like you said, when you have other people talking for you, they're going to interject how they think you're feeling. And I think that's important, to just let a child or a patient speak for themselves.
Yeah, it goes back to that chronic invalidation. Invalidation actually is a lot of science behind invalidation of the disease process, a lot of science behind it. So have you noticed any upticks or trends in the brain gut disorders?
Right. I mean, I think, I do, first because it's, again, complex. And I think our world is, rapidly changing in terms of biopsychosocial, but also, diseases, illnesses, allergies. So all these things we're talking about, like, are triggers for the gut, because the gut is receiving so many thousands of stimuli. So we see an uptick in allergies. We see an uptick in autoimmune disorders. We see an uptick and so I can't help but think there are environmental influences to this, right, as well, that we don't fully control for, fully understand. We have the same genetics, but remember, genetics play out with the environment. I definitely know from a psychosocial standpoint, in this growing age, kind of information overload, teenagers on their phone, social media, coping, attachment, isolation. They're so popular. They have, thousands of friends online, but no real friend to really talk to, right? In real life. It's such a different time. And the other thing, at least in my world, because it's children, their frontal cortex is still a work in progress. It's not fully developed or mature, right? It's still growing. It's still evolving. It's still developing. And so some of this cognition mood thought, which you would think, okay, a 25-year-old probably is, pretty much there, matured. But yeah, even a 17, 18, 19-year-old is still maybe developing some of that. Those are not necessarily, those pathways haven't fully matured or established themselves. And they are a product of their environment. They're a product of what they see. They're a product of how they see their parents cope and their social situation. And also what they learn from the internet. Because while, coming back to your point of, validation and, always, making sure that we're really listening to our patients, you have people who go and they're like, oh, well, we saw this or we saw this movie or we heard this or we went on this Facebook page and what have you. And then they're all coming in mimicking these symptoms, right? So it's just like you have to, again, listen, but have to be cautious and identify and make sure there isn't any, malingering or secondary gain or something else that's involved, which is important because some people will want to have copycat syndrome and be just like that person who got all this. So it's important because, again, there's accessibility to all of that. And so you have some people who will, try to take advantage of the situation and think that they can, again, there's some secondary gain. It's a cry for help. Regardless, it's a cry for help one way or the other, but it may be for the wrong reason. So nonetheless, validation is important, but also, we're always, making sure that there isn't anything else that's going on that we should be aware of.
Yeah, and you hit secondary gains, and that in itself is, I can't wait to dive into secondary gains because it coincides with different phases of healing that people go through the disease process. And you pretty much just took all my sentiments, exactly how I feel. I'm like, yeah, that's so spot on when it comes to social media and exposures. And I remember when I got schooled, because I'm always so comfortable admitting my parenting flaws. My child was going through something and it ended up being stress and we ended up fixing it. But we ended up in a neurologist's office and I got schooled hardcore. And I'm so grateful for the schooling. To this day, I will thank him to my last breath. He says, why is your third grader talking to me about college, going to Harvard? He's like, I got a room full of patients in there right now who are stressed about where they're going to college. Why does your 10-year-old care where she's going to college? I left that office sobbing, but the most grateful I've ever been. I was like, why is my 10-year-old talking about going to Harvard? Oh my God, he's right. What am I doing? Why is my 10-year-old talking about going to college? What am I doing wrong? And that's where I even met you. So these things like the internal, external pressures we put on kids, the secondary gain that she got from stomach aches got her out of the pressure of having straight A's in third grade. Who cares if my third grader has straight A's? Why I cared back then, I don't know. I just wasn't informed. But it's learning through this process. But back then, it was so much pressure. So the social media, the pressure from the parents, the stress that we put on our kids, the secondary gain, which I have found, has been tummy aches. And then it creates a miswiring, the neurobiological miswiring, then does create an actual disease process because they've learned, oh, I got to miss school. My parents didn't nag me about studying for the test. They had a true stomach ache with all that stress. But then on a subconscious level, they learned, wait, I got out of that stress. I got out of that nagging. I got out of that pressure. And then the brain and the gut begin to wire, oh, wait, pressure? Let's miswire this. Let's miswire this. Let's get you sicker. And it's this cascading event. So when you said secondary gains, I'm like, ding, 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 ding. Significant role in this whole brain-gut interactions, significant. And it's so difficult for me to introduce that concept. So I have to kind of tiptoe into it because you don't want to, upset someone. But it feels validating for me that you said you you see it too.
Absolutely.
So What is one thing that you wish you could tell if you got to do a mulligan all over again as a mother, as a pediatrician, specialized in GI? What's the one thing you would tell parents, women that are pregnant, women with toddlers, as it relates to what you now know about secondary gains and gut-brain interactions and how prolific they are?
Yeah, that imprinting, that neural imprinting, I mean, and the biology of how it starts, so even at the embryonic level, these, neuroendocrine cells, they migrate from the gut to the brain. And it's this, delicate physiological, embryological, histological development of, these organs that are occurring simultaneously. So even in the pregnancy phase, preconception, they've talked about stressors in the preconception mode that actually, will imprint and cause, effects downstream. So my advice is simple. As best as you can, avoid the insults and the stress as best as you can. Feed your body with not just good nutrients, but good thoughts, good habits, good function. Some things we can control, and some things we cannot control. But if in a developing body, in a young body, if you unnecessary use of medications or antibiotics, for example, that's really simple. Like the ear infection, you get 8 antibiotics in that first year of life. That's terrible for your gut microbiome, right? So it's like things that sometimes people are misinformed or uninformed, or just misinformation overload, and you think you're doing something good and it's not really something good. And again, that, imprinting early on, how a child, even like listening to the mother. So if there's, screaming or yelling or stressful environment, I mean, that affects you. That affects a developing, a young child, an infant, a toddler. So, those kind of things, I think, just being kind of as much as you can, feeding yourself with nutrients, with surrounding yourself with positivity, relieving or kind of avoiding the stress. And that's easy for me to just say, but the practicality of that, especially when you're struggling with things and you don't have food, security, and so on and so forth. I know what I'm saying sounds wonderful and rosy, but I understand that for a lot of people that may not be their reality. And the point that is that, again, especially in a child who's developing, things that happen early on, early life experiences, do really shape who they become and how they cope and how their body does. And there's a complex biology that supports it. So if I could do it all over again, I know that I would definitely, like you said, take it easy with my kids. I mean, my kids are now 16 and 12, so they're still, young and growing. But yeah, I mean, the things that I stressed about, and I'd probably be a lot more relaxed and probably just maybe, show myself some more grace, because it was always like driven. And just sometimes it's okay. So it's okay to just, take a breath.
Yeah, it's one of the things I just recently told, I think it's a mutual patient with, I think, Dr. Pandy, I think another physician in your practice, was I told the mother to start modeling meditation. And that her 10-year-old, if the mother would take time out for herself and just lay on the pool deck, look in the sun, spend 10 minutes out there, put her feet in the grass, that her 10-year-old daughter will start modeling that. There's no major changes to do with your daughter. You model for it, and she's going to start copycatting you. And that's just probably going to be your quickest fix. You take care of mom, then your kid's going to take care.
100%. I always say, don't tell kids what to do, show them what to do. Don't tell your kids to put your phone down if you're going to be scrolling on there yourself for 4 hours.
Yes.
Don't ask you to put your phone down. You put your phone down first.
Yes. Exactly. And then you mentioned in utero, and I want to do I'm doing a whole separate book on that. It's called Automatic Loving Thoughts. What if we, seriously, legit think about this? We have like 20 to 30,000 negative thoughts a day. What if we started training our children in utero? Because the brain that develops in utero is a brain that's going to be born out. So if you are stressful as a mother, your child's brain is going to be wired for a limbic response.
100%.
So what if mothers could start thinking automatic loving thoughts? Maybe get down to couple hundred negative thoughts. You've now rewired your baby's brain differently. You then imprint on your newborn. You are kind, you are smart, you are important, you are valuable, you are loved. If you legit think about this, if we can create this world of automatic negative, why can't we create automatic loving? Why can't we start teaching mothers and fathers preconception, start automatic loving, conception, automatic loving? When your baby is born, it's born in the environment in which it was in utero. So mothers, if I could go do it over again, I would imprint myself with automatic loving thoughts that took me 20 plus years later to figure out how to do. And then my children be born that way. And it's just, what a different world that would be.
It would be. It really would be. Because you're so right, that imprinting, that early life, and we're consumed, and we know that stressful pregnancies and stressful deliveries and stressful outcomes, health outcomes for those kids, because it happens early on. But like you said, the negativity is a given. Why can't we build the positivity and those positive thoughts? It needs to happen, and there needs to be classes on that, prenatal classes on how to start that early, because that's a brilliant concept. It needs to happen.
Well, it's not my concept. Actually, Dr. Stanley Brown, I sent her a clip of something. She's like, I need to be handing this out to my pregnant parents. I'm like, oh, well, that's a good idea. Let's start doing that. So where can people find you? Do you have any publications or projects, or how can people find you?
So I've been working at the Arnold Palmer Hospital for Children at Orlando Health. I've been there for over 15 years now. I finished training in Cleveland, Ohio, and I've been here ever since. So that's where I'm located physically. And yes, we do research with our fellows, and we're publishing some of my recent articles in JPGN, Journal of Pediatric Gastroenterology and Nutrition. My most recent one was talking about GI manifestations with small fiber neuropathy, which is, again, evidence of nerve injury on a skin biopsy level correlating with GI motility disorder. So that's my most recent publication in JPGN. But yes, we're at a institute which supports academics, and we have a fellowship program. And I've been director of the neurogastrointestinal motility department there. So I'm here in Orlando. Hopefully plan to be here a long time.
And I sometimes get in contact with the fellows that have worked with you, and you're definitely leaving a ripple effect out there into the universe. Absolutely. And what they've seen you do and the validation. I have no affiliation to APH, guys. I legit don't. I'm genuinely speaking from the bottom of my heart. Just what I have seen there is just remarkable in comparison. It just truly is. And this is just a personal, authentic plug, because it has changed so many people's lives that I've seen, which is so different from the other hospitals and groups that I work with. I am completely honored to have you on, and very, very grateful. Thank you so very much, Dr. Safder.
Well, the honor is all mine. It was absolutely, I feel like we can just keep talking forever, but I had so much fun. Thank you for having me. And it was wonderful reminiscing about our common patients. So thank you so much.
So much more of what Dr. Safder and I have discussed in great detail I describe in the book, and it's Empower Your Child to Heal. It's understanding the secondary gains. It's understanding attachment styles and the healing phases, and the bi-directional communication of the brain-gut axis, and these 8 techniques and methods that I'm going over in these podcasts and exploring is the different ways to look outside the box in the mind-body connection. And there's also a book coming out for people without children, just Empower Yourself to Heal. And it's taking this deep dive into all the angles that no one's really looking at in the mind-body connection and to heal ourselves. And it's understanding on a deep level about anxiety and disease process. I also have some workshops and retreats coming up in the fall, and I have some expert mind-body coaches and somatic practitioners that'll be helping with this. So it's going to be this really cool experiential retreat, getting into the mind-body connection and somatic wellness. Please feel free to go get some free newsletters and some free downloads and tips from drskyler.net, and abundant blessings to you all. Thank you for your time. I feel so grateful you have listened to the end. When we begin to understand how our body manifests stress, trauma, depression, anxiety, and even unexpressed emotions, we then create a space, a bandwidth in our minds to begin to heal our bodies. Healing is a decision, and I am grateful for yours. Abundant blessings, Dr. Schuyler.
To learn more about the work Dr. Schuyler is doing, please visit drschuyler.net. That's drskYler.net. And remember to subscribe to this podcast wherever you like to listen.
Produced by Audavita Studios. Connect your voice to the world.